pandemic itself in strengthening health systems on the continent to prepare for this day. I think when we started our partnership, we didn't know that we were going to engage or be challenged with a pandemic of this nature. And it is a good example of what I usually refer to as the need for us to strengthen our systems before we need them, and rather than strengthening health systems during a pandemic. So Amanda, please welcome to this platform, and we really deeply appreciate our very strong collaboration. So as usual, I'll divide my comments into three parts. First will be the epidemiological update, then what Africa CDC is doing. And in that, during that segment, I'll bring you up to speed on my visit to Morocco. That is the reason we didn't have a briefing last week. And then conclude with the vaccination situation before I turn it over to Amanda to discuss the public health and social measures that we believe are so critical for us to continue to implement. So first of all, on the epidemiological situation, as of August 26, that is today, 7.6 million Africans have been infected by the COVID-19 virus. And of that number, about 6.7 million have actually recovered, and this represents an 88% recovery rate. Unfortunately, 191,000 deaths have been reported across the continent, with a case fatality rate of 2.5%. And if you put that number of deaths in the overall context of the total mortality rate recorded since the start of this pandemic, it represents 4.3%. A couple of countries, as always, the top 5 countries that are bearing the most burden on the continent include South Africa with 36%, Morocco 11%, Tunisia 8%, Libya 4%, and Ethiopia 4%. In terms of where we are with the third wave and fourth wave, as you recall, we mentioned last time that 69% of our member states, that is 38 countries, are now experiencing a third wave. 29 of those countries, or 76%, are experiencing a very severe third wave. And the definition of that is that the peak of the daily cases is higher than what we saw during the second wave. 2 additional countries, that is Angola and Sahrawi Arab Republic, have since become additions to countries that are experiencing the third wave. 4 countries, that is Kenya, Algeria, Somalia, and Tunisia, are now experiencing a fourth wave across the continent. So no new addition additional country has added to the list of the countries that we indicated last time. So where are we with the variants? For the 3 countries are now reporting the Alpha variant. 1 additional country, that is Eswatini, has now been added to the list of countries reporting the Alpha variant. 37 countries are now reporting the Beta variant, with no new additions since the last time we discussed this. 32 countries on the continent and slight decrease there. The highest proportion of new cases are coming from Southern Africa with 46%, North Africa 37%, East Africa 9%, West Africa 7%, and Central Africa 1%. In terms of deaths, the continent has recorded over the last week 5,500 new deaths, and this represents a decrease of 10% if you compare that to the previous week, where we recorded 6,225 deaths. If we now look at the trends over the last 4 weeks, we have the following observation. That is the week between July 26th and 22nd of August. We have observed a slight decrease, a slight increase over the last 4 weeks of 0.3%. Again, 0.3% slight increase. And the following trends have been observed in the regions. 8% increase in Northern Africa, 8% increase in West Africa, 6% increase in East Africa, and 10% decrease in Central Africa, and 5% decrease in Southern Africa. In terms of deaths, if you look at the last 4 weeks, we have observed a 4% average decrease in new deaths across the continent. For testing, as a continent, we have conducted 65 million cumulative COVID tests since the start of this pandemic, with 1.5 million new tests conducted last week. And this represents a slight decrease of 4% compared to the other week where we had conducted 1.573 million tests. The cumulative positivity rate still stands at 11.7% and a test per case ratio of 8.6. 25% of our member states, or 14 countries, are now reporting a test positivity rate that is higher than 12%. So in terms of new developments, we continue to support countries in several areas. One is to provide them assistance with infection prevention and control measures, and also working to improve WASH in healthcare facilities by training a total of 1,900 participants, especially in anticipation of in countries where the Ebola outbreak has been reported and the Marburg hemorrhagic fever. Two important announcements. One is that yesterday we did sign a memorandum of understanding with the International Federation for Red Cross and Red Crescents, abbreviated IFRC. This is very important for us because we believe that this pandemic will only end if we work closely with the community. And IFRC has a very large community-based program. So we really want to partner with them to expand testing and also see how we can use community healthcare workers to drive the vaccination programs. The second thing is just an announcement that the Africa CDC will be hosting a One Health conference exactly on the 1st and 3rd of November this year, and really to promote the concept of One Health. We know that more than 70% of our infections come from animals. So this case will be an opportunity for Africa CDC to continue to advocate for the need to strengthen One Health, especially as this pandemic has taught us that we cannot do this in isolation. So before I go to the vaccine update, let me just pause and give you an update on my visit in Morocco. I was in Morocco with a small team to meet with the Ministry of Health officials as well as the Minister of Foreign Affairs. And I must say it was a very, very impressive visit in several dimensions. One was to see how Morocco is expanding its vaccination program. In my view, in terms of size, Morocco is the leading country now in Africa, where they have administered 16 million first doses of vaccines in a population of about 25 million eligible people that should get the vaccines. So that gives you more than 40% eligibility of people that have been vaccinated with the first dose. And if you look at their second, people that have received both doses, there are 12 million out of the about 25 million have received both doses there. So that puts Morocco around 45 to 50% of those that have received double dose. Very, very encouraged. What was fascinating to me was how they have set up the vaccination centers across the country with a very a tight program that is monitoring how things are going on in the countries. That is, you could go into a command room and actually see in real time how the numbers of vaccinated people and how what kind of vaccines they were using. They're very, very impressed. So they've done that with using several approaches there. One is to develop, they develop a public-private partnership arrangement with the private sector, which was driving the vaccination centers in Casablanca. And up north in Tangier, they were using the sports complex, the stadium. And you could see long lines of people meandering and winding inside the stadium and outside. The young people, I was impressed to see young people queuing for hours and hours and lines to get them vaccinated. But there was a lot of innovation where they brought in final year students in medical schools and nurses, bring in the military doctors and the Ministry of Sports to really work together using the whole of government approach to scale up vaccination there. So I think that is one of the lessons that we hope that other countries in Africa, we can actually facilitate other countries in Africa to go to Morocco to see how they are doing this. Because as I said, by population, they are way ahead of many countries in Africa. The second thing that was very impressive is the locally produced COVID tests that it takes just 2 hours to do a PCR test. And we have actually last year participated in the validation of this test. And it is made in Morocco, made in Africa test. I can't be more proud of that. So we will be, in the coming weeks, be working with them to see how we can procure those tests and use them across multiple countries to support our programs. The third thing that emerged there was really what they have done in terms of producing locally public personal protective equipment in terms of masks and protective gowns that are certified, and they're actually exporting to some European markets. There we were very, very impressed with that. And what was even more fascinating was that in the coming weeks, they want to set up production sites in many countries, including in sub-Saharan Africa, including in Côte d'Ivoire. We saw the machines that have been acquired and ready to ship to Côte d'Ivoire to set up a production site there for masks that really made international standards. That was extremely encouraging. So we thought that was a very productive visit, especially from the lens of how the continent is moving. Our overall continental average, as I would explain, is very, very low. Average number of people that have received full vaccination, but Morocco is really an outlier. So that is a nice segue to discuss vaccines. Where are we today on the continent? As of today, we have received 130 million COVID vaccine doses in 53 member states. And of that number, we have administered 93.5 million doses of vaccines, and which represents a consumption rate of about 72%. The overall coverage stands around 2.5%. That is people that have been fully vaccinated with the 2 doses there. Again, as I indicated, countries like Morocco, South Africa, Egypt, Tunisia, Nigeria begin to make very good progress there. Just last week, the United States donation continues. Kenya received 880,000 doses of the vaccines, and that is the Moderna vaccines. And Togo received 180,000 doses of the Pfizer vaccine, and Rwanda received about 489,000 doses of Pfizer vaccines. UK donations are also underway, where Ghana has received 249,000 AstraZeneca vaccines. Angola has received 128,000 doses, and Nigeria 700,000 doses. China donations include 200,000 Sinovac donations to Togo and 200,000 Sinopharm donations to Rwanda. On the 23rd of August, Rwanda started the 3rd phase of vaccination campaign targeting people over 18 years old. I think that is a very, very encouraging experience. So let me just conclude by making a few remarks that will be a segue to introducing Amanda, who, as I said, is a vice president, senior vice president for preventing epidemics for the resolve to save lives. The COVID-19 is here with us, and unfortunately, let me say that from the look of things will get more challenging before they get better, which means we have to begin to look at how we manage the pandemic in its totality and moving from an acute phase of the response to actually managing it as a program. And why is this important? When vaccines alone, especially given the slow rate at which vaccines is being introduced on the continent, will not solve the problem for us. We have to use a combination approach where we promote the use of public health and social measures to begin to continue to avoid the occurrence of wave upon waves, which are extremely damaging to our economies and damaging to even our own ability to live normally. So I think, as I indicated earlier, about 38 countries are currently experiencing a third wave. I have no doubt that they will bring it down, the peaks down, but then there will be other waves. But if we continue to implement the public health and social measures that Amanda will be discussing here today, I think we have a very good chance of identifying the hotspots that will become, will become the subsequent wave on time to take action. I think that is extremely important. So I think the partnership with Resolve to Save Lives has been one of those critical aspects of our collaboration to implement our adapted continental strategy, which, if you recall, on May the 8th, the ministers endorsed it, which speaks to the need for enhanced prevention, enhanced monitoring, and enhanced treatment. So it is in that context that Amanda will be speaking to us about what we abbreviate all the time as PHSM, which is public health and social measures, which will be critical in designing alert systems that can point us to where the hotspots are. And we do kind of what are called mini lockdowns, right, rather than do national lockdowns or regional lockdowns, which are becoming extremely devastating. So Wayne, thank you, and over to you to introduce Amanda.
Thank you very much for that brief. That was Dr. John Nkengasong, who is the director of the Africa Centers for Disease Control and Prevention. Yes, indeed, we are joined by Mrs. Amanda McClelland, and Amanda is the Senior Vice President of Prevention of Epidemics at the Resolve Save Lives. So in that capacity as the Senior Vice President, she leads the prioritization and planning of interventions and support in identified countries and regions with the view to strengthen the action packages in the prevention, detection, and response to epidemics. So Amanda, good morning, and it's over to you for your brief.
Good morning, and thank you so much for the kind words and the collaboration with Africa CDC. I'm very pleased to speak in more detail around the PHSM framework that Resolve to Save Lives has developed in collaboration with the Africa CDC and the World Health Organization on the continent to really support countries to use informed decision-making. And as Dr. John mentioned, the idea that we need to manage COVID in the longer term is definitely here with us. And this idea of completely opening or closing down countries with very strict PHSMs is no longer an option like it was at the beginning of the pandemic. We can't really have officials just shutting down full societies, but rather we need layered policies that are appropriate for COVID control that manage the balance between controlling transmission, keeping health facilities open and essential services open, and maintaining the economy. And so this is really why the PHSM tiered framework is being proposed to member states to really use data and indicators at clear thresholds to be able to understand the amount of COVID in the country, help determine which policies countries should put in place, and really communicate that to communities so that, as Dr. John said, with the IFRC, really mobilizing community members to adhere to those PHSMs and to cut the length of time those waves that are occurring in many, many countries right now. This approach was really adapted from some fantastic experience early in the pandemic by South Africa, who had a very clear alert level system. We saw similar approaches applied in many countries, including New Zealand, who did it very, very well in the beginning of the outbreak, and were able to clearly communicate the different levels of PHSMs for their communities. So to speak more specifically about the PHSM framework, to be effective, it really needs to be clearly understood. Why are we using PHSMs, and why did governments make decisions to open or close different policies? It needs to be transparent so everyone knows why those decisions are being made. And to do that, it needs to be data-driven and practical. And as John said, really customized to the smallest geographical region. So we're really focused on where the COVID is rather than very large-scale, broad policies. It needs to be collaborative. It needs to be in partnership with private sector and the government, as well as communities, reinforced by strong legal and proper oversight and supported by wide dissemination of the information, which is really why we're talking to you today. The media plays an extremely important role in building trust and supporting clear evidence-based communication, helping governments and partners communicate not just what restrictions are in place, but how communities can protect themselves individually and as a community, how they can adhere to those PHSMs, and what they need to do to be able to reduce caseloads so that communities can get back to normal. So we really hope that this new framework, supported by Africa CDC and WHO, will allow countries to take the lessons learned by many countries already on the continent, apply data-driven decision-making, and really find that balance in controlling the COVID waves, continuing to roll out the vaccine, and helping manage the economic impacts that restrictions put in place. So I'm happy to, in combination with Dr. John, take any questions and go through more detail around the framework.
All right, thank you very much to our colleague there from Resolve to Save Lives. And that was Mrs. Amanda McClelland. All right, it's time for us now to go to our question and answer section. Before we do that, let me give you the numbers or the contacts that you can use to send in your questions. The first one is that usual WhatsApp number +251 94 550 2310. But today we have an alternative number in case you cannot get through to that WhatsApp number. And the alternative is +251 904 139935. Let me give you that number again. +251 904 139935. But you can come through live or utilize the question and answer section. All right, talking about coming through live, let's go live to our colleague in South Africa at the SABC, and that is Sophie Mokoena. Good morning, Sophie. Please go ahead with your question.
And that is Sophie Mokoena. Good morning, Sophie. Please go ahead with your question.
Thank you. There are two questions, and the third one will be directed to your guest. The first one, Dr. Nkenkesong, the issue of vaccine hesitancy. Are we still having a problem on the continent, or it is getting better? And then the second question to you again, Dr. Nkenkesong, how far are we in terms of reaching herd immunity? And looking at the rate in which we are vaccinating the population on the continent, do you think we will be able to reach that herd immunity? And then the last question to your guest, you spoke about how South Africa was able to come up with a strategy or program or a plan to deal with COVID-19, considering all issues during phase one or maybe first wave and second wave. And even now, I think it is the same at a time where they are now pushing a vaccination drive. And our public broadcaster in South Africa, SABC, today having pop-up vaccination site as part of public service to the public and also to the continent. Why the numbers, much as South Africa is doing all that, why the numbers in terms of COVID-19 cases is still high, and we are still an epicenter, even on issues of vaccination, with all the initiatives, including today where the public broadcaster is also on the same campaign to assist ordinary South Africans and the Africans on the continent in general. We are still not seeing numbers growing in terms of bringing down the deaths and the infections, but also vaccine towards reaching that herd immunity.
Thank you very much, Sophie. Let's start with Dr. John.
Thank you, Sophie, for, as always, asking very tough questions, but very pertinent questions. Based on what our observations and country by country observation, our vaccine hesitancy situation is actually rapidly improving. And I've tweeted this for those who follow me on Twitter, I mean, with evidence showing long lines of people, whether it's in Kenya or Rwanda or Morocco. As I said last week, I was visibly emotionally shaken to see long lines of meandering young people, young men and women in a stadium in Morocco waiting patiently to be immunized. From country after country, Senegal, Botswana, Malawi, their issue now is give us the vaccines, not longer issues of whether they should take the vaccine or not. So I think, having said that, there continue to be and will always be small pockets of individuals that will continue to have doubts about vaccine. But as I've said earlier, this week, let's all launch a campaign on what I call a social contract. A social contract, which means I am vaccinated to protect myself, to protect my loved ones, and to protect my community. And I'm also want to know my COVID status so that I can take personal action there. That kind of a social contract is so much needed now. We are in this for a very long haul, Sophie. I mean, there's no doubt. I mean, I think, as I said earlier, the situation will get worse before it gets better. And we better prepare for a long haul by signing a social contract within ourselves that says that we have to take individual responsibilities. And if vaccines are available, let's go get our vaccines there. But let me leave you on that with a very clear message that vaccines do not prevent you from being infected. Vaccines prevent disease and prevent that you are hospitalized or you die. I think this is very, very clear. I think and because of that, we have to take a long haul approach to this. And as Amanda said, using a combination of public health and social measures together with vaccines is very important. We are not going to vaccinate ourselves out of this pandemic anytime sooner in the next 1 year or 2 years. Absolutely, based on what we know. Our knowledge of the virus is improving, but again, we have to be humble to say that we still don't know what we need to know all about this virus there. Like when we started the vaccinations just a few months ago, we thought, who knows, if you get vaccinated, the immunity lasts for several years, but we see that immunity wins and that the vaccines are being challenged by the Delta variant there. So these are all new knowledge. New scientific knowledge that we need to factor into what we are doing. Are we going to get to herd immunity? I doubt that that notion is irrelevant anymore. Herd immunity, by simple definition, is where you vaccinate a certain percentage of the population, and that people that have been vaccinated now become a shield where they prevent the transmission of the virus. The fact that today people that are vaccinated can still be infected and transmit the virus to the next person suggests that that concept, again, it will be challenged by this virus. And that's what makes the virus or the situation very complex to manage. Unlike other viruses that, once you vaccinate a sizable proportion of the population, you get rid of that. Is Africa going to get to that target? We started off saying that we should vaccinate at least 60% of our population to achieve herd immunity. That was based on the science and the knowledge of the virus we knew at that time, which was last year, if you remember, last August. Today, what do we know about this virus? The virus is, especially the Delta variant, is more transmissible than the wild type that started this pandemic. The R0, which is the rate of reproduction of the virus, is for the Delta variant is about 8. Which is significantly different from where we started with an R0 of 2.5. So all of that changes the equilibrium on our need. If we ask us today as Africa CDC, where should we be to achieve at least a sizable protection of our community from developing disease, I think we should be vaccinating in excess of 70 to 80% now. Another new information and knowledge that is emerging is that the young people are now getting sick. And when this pandemic started, if you recall, young people were infected, but they just move around. But now they are getting sick, and we have seen that in hospitals. So we continue to learn more about this virus, and based on the new knowledge, we'll continue to adjust our strategies.
Thank you very much. Over to you, Amanda.
Thank you so much, and thank you for the question on South Africa. I mean, given that I'm not there in the country, I'd be reluctant to dig into the details. I think the public health teams in South Africa have been doing a fantastic job from the outside. But at least as we look across the continent and why South Africa continues to have what looks to be higher rates than many other countries, I think is multifaceted. Although they have used PHSMs very effectively, they have turned them on and off. So as caseloads come down, they have opened back up for economic reasons, rightly so, and they have seen increases in cases once the measures come off, and then they're using those again as the caseloads get up. So they have had 3 very distinct waves. They do have a higher median age than many other countries across the continent, which has perhaps led to those higher death rates. They also have higher prevalence of non-communicable diseases and those other comorbidities that we've seen really impact infection and death rates. And it has to be said, they have much better testing than many other countries on the continent, which perhaps increases their reporting rates. But when you compare South Africa globally, obviously in Africa context, it looks much higher than many other countries. But when you compare South Africa against similar countries globally, they are very similar rates or even lower rates than other countries. So I do think they've done a good job at communicating when and how to use PHSMs, but those economic impacts make it very, very hard to maintain them in the long term. And we have seen very distinct waves of social measures used in South Africa.
Thank you very much for that. We move on now, and we have Sarah Kimani, who is coming to us live. And I believe Sarah is in Nairobi and also representing the SABC. Sarah, good morning. Please go ahead with your question.
Good morning, Wayne, and thank you for having me. I wanted to find out from Dr. Nkengasong, when you look at the data that you are receiving in terms of the number of infected, the number of deaths, and even the number of vaccinated, how would you rate it? Are you finding that among us in the continent, the countries that are well developed are probably keeping their data better? And so it is possible that even the numbers that you give us every day may not be the true reflection of actually what is happening on the continent. Secondly, Kenya is among the countries that have covertly introduced vaccine mandates, at least for the civil servants. And we know also of offices that are now saying, if you're not vaccinated, even if it's a first dose, do not come to the office. Is it something that we are going to see as we move forward? And what is your, experience of vaccine mandates? Do they work? And how about the human rights issue when it comes to vaccine mandates?
So thank you, Sarah. The first question, I'm afraid I didn't get that. It was on the reporting of numbers of vaccines or numbers of COVID infections.
The number of COVID infections, maybe vaccines, you may have the proper numbers because that is coming from you. But in terms of the number of infections, do you feel we now have a clear picture, or there are some countries that are still underreporting, either because their data collection is not very good or because they are not testing enough?
No, absolutely. I think for the numbers reported, I mean, and we are very clear and highlight that word reported. These are numbers that we are getting from countries. I mean, and I think we shared with you on this same platform a few weeks ago on the serologic analysis that we did. Okay, that is generating primary data, where the question we asked was, in a given country, have you been exposed to the virus or that is infected with the virus or currently infected with the virus? And we use serology to define that. And if you recall from that press conference, we shared data in Uganda, I think Sierra Leone, and the numbers were significantly higher than what is being reported, which is meaning that the numbers that you get from the PCR reported number confirmed cases there are lower, significantly lower than what it is actually going on there. So I think we have published in Science that our situation of COVID on the continent continues to be a puzzle because of this discordance. And many factors will explain that. The low rate of testing as a continent of 1.2 billion people. I think we've tested, as I indicated today, about 65 conducted about 65 million tests, and you see where our case test ratio is still not where it has to be. And I think we will be in the coming weeks be launching the partnership to accelerate COVID testing 2.0, which will go side by side with the public health and social measures that Amanda is just described here, so that we do large-scale testing using the antigen test and actually know who are the active people that are actively infected and do something with that. It could be just be a simple process of isolating people, making sure that they isolate themselves for a number of days and then retest before they get back into the society. And that is what I'm referring to, social contract, where people know their status and they take actions there. Gone are the days, as we described earlier, where we're talking about contact tracing. If you are positive, we find your contacts, trace your contacts, and isolate them. I think the pandemic is in a very different place today. So I think that the short answer to that question is that we clearly are not reporting all the cases that are happening on the continent. With respect to vaccine mandates, let me be very clear. Of course, we have to respect human rights. But again, I insist on the need for all of us to sign a social contract with ourselves and say that by vaccinating, you have the obligation to protect yourself. These vaccines save lives, but they also save your neighbor and they save your community. So until we do this social contract with our own selves, we will continue to be challenged. We are not going to vaccinate ourselves out of this pandemic that quickly. Given what we now know with the duration of this, the immunity, the need for vaccines to be scaled up quickly. And if you see where we are with just 2.5% of the total population of Africa, that the eligible population on the continent of 1.2 billion people, then we have a long way to go before we get there. So I encourage whether countries are requiring mandates or not, that people voluntarily go get their vaccines. They are safe, they are effective in preventing deaths and in preventing hospitalization.
Thank you very much, John, and I will stay with you for this question coming from Sarah Jerving, who is with DEVEX. And Sarah says, the World Health Organization has asked countries to conduct self-assessments on their vaccine rollout preparedness. Some countries have not submitted these assessments to the WHO and have not submitted national and micro-level district plans for the rollouts. So the question is, are you concerned that some countries don't have detailed vaccination plans?
All countries should by now have detailed vaccination plans. And we have also at Africa CDC engaged member states region by region to understand that where they are with their vaccination plan. And I think we're very impressed that many countries on the continent have developed a comprehensive COVID vaccination plan. And that plan provides a platform for coordination with partners and coordination of resources there. So I think we are very encouraged with that. Have all countries done that? Not yet. But we encourage those countries that still have not developed such plans to do so, because again, this is an issue of collective responsibility and collective accountability.
All right, thank you. I wonder, Amanda, if you might have a comment on that, seeing as though it's your specialty as well, just very briefly.
Nothing more to add than John. We've been working with, I think, about 24 countries on the continent in collaboration with WHO on micro planning. It's very difficult to plan when you don't know what supply is coming. I think this is a huge challenge. The numbers that John mentioned, with smaller numbers of vaccines arriving in countries from multiple channels, makes it a challenge to plan. We continue to support countries to adjust their plans based on availability.
All right, thank you. I will go to the questions coming through our Q&A. And the first one is from Judith Akolo. She's really seeking clarification from Dr. John. She says, Dr. John, kindly clarify, is the Delta variant becoming a challenge even with the vaccination?
Yes, absolutely. The Delta variant is a challenge, both in terms of the transmission. The Delta variant, as we know, you and I know, has the ability to transmit a lot faster and easier, with an increase of almost about 40 to 50% increase. And it also poses a challenge to some extent across the board with vaccines. But the key thing here is that, Judy, that it has a low, the vaccines have a diminished effect on them, but it's not like they don't work. They do work. I think these are vaccines that mainly generate neutralizing antibodies. So even if the neutralizing antibodies decrease somehow by 1/4, they still offer a level of protection. It only speaks to the fact that to get out of this pandemic, we have to vaccinate massively, and not just certain regions of the world, because variants will emerge and will continue to emerge and may challenge the current vaccines that we have in a significant way. Today we are dealing with Delta. Tomorrow we just don't know what variant will emerge and how much impact it will have on the current vaccines that we have there. So it is again in our common interest to vaccinate at speed and at scale. Let's look at the situation in Israel. Israel was a model country. They vaccinated very, very early on and reached a very high level. And then they opened up and celebrated that, but see what is happening. I think nearly all infections in Israel now are the Delta variant, and there are people that have been vaccinated with the Pfizer vaccines, and others are being infected. But the beauty is that they are infected, but the death rates and hospitalization is significantly lower. I think really, really significant. If you look at the graphs, it's like this, okay, where people that have been infected but had their vaccines, they are sick, but they don't actually get to the hospital and they don't die. Then people that were not vaccinated really suffer a lot of mortality and then end up in hospitals. So the Delta variant truly has an impact, especially with the ability to break through the people that have been vaccinated.
Thank you. We have a question coming from Bloomberg News in Abidjan, and it's coming in from Katerina Hohi. And she says, I have a question regarding the suspected Ebola case in Burkina Faso. Has it now been confirmed as Ebola? And if not, when do you expect confirmation? And also, are there any links to recent cases in Ivory Coast and outbreaks in Guinea?
So we are monitoring the situation in the sub-region very, very closely for the Ebola outbreak, especially in Côte d'Ivoire. And once we have more details on the situation in Burkina Faso, we'll be happy to release that. But for now, information is not yet complete to inform our knowledge and pronouncement on if it's a confirmed case there or not. So we'll just stay tuned, and we'll be happy to bring you any updates in our subsequent briefings.
Thank you. Let me put this one to Amanda. And it is coming again from the South African Broadcasting Corporation, but this time the radio channel that is titled the Channel Africa, and it's coming from Pamela Kumba. Pamela says some people are already speculating about a fourth wave coming up because of the reluctance to get vaccinated. Do you think there is a possibility of a fourth wave? Amanda, that's for you.
Thanks so much for the question. I think as we talked about at the beginning of the press conference, we're going to have to find a way to work with COVID in the longer term. I think the availability of vaccines is a much bigger hindrance than hesitancy at the moment. I think we have a long way to go to vaccinate the continent before we really reach levels where hesitancy is the main obstacle. But so the potential for a fourth wave is definitely there. We see the waves coming fairly consistently across all countries, including on the continent. And it is likely that a fourth wave will occur before we get vaccination levels high enough in enough countries to limit the wave. I think what we're trying to do is to make sure that those waves are as short and as flat as we can, and to make sure that we really protect against the hospitalization and severe disease that the vaccines are really supporting us with. But we need to layer until we get the vaccine levels required to blunt the curves, to flatten the curves. We remain to use all of the tools in our public health toolbox, and that includes the public health and social measures at community level and at individual level.
All right, thank you very much, Dr. John. The next question is for you, and it's coming from Esther Nakazi, who is a freelance journalist based in Uganda. She says, in terms of the mini lockdowns that you have mentioned, how big should be the geographical size? Are we talking about a village or a district, or exactly how big should it be?
I think let me first of all just compliment, say a few remarks with respect to what Amanda mentioned and what Sophie earlier talked about, vaccine hesitancy. I mean, a few weeks ago, I tweeted on this. I said, our problem is vaccine famine and not vaccine hesitancy, because the situation has changed completely on the continent. I think the biggest challenge is predictability on access to vaccines so that you can plan. There are about 6 different vaccines out there. They come in all kinds of forms, and they require different conditions to roll them out. How can you plan as such? I think that is the challenge, one of the greatest challenges that we have. And some of the donations that we are receiving, member states are receiving, have a very short lifespan or shelf life. So how can you plan with that? So I think those are some of the challenges that are out there. And then if you don't know exactly what vaccines you are going to get and what will be the expiring date, it's very difficult to plan. Some countries, because they are now receiving the Johnson & Johnson doses that the AVAT mechanism, the African Vaccine Acquisition Task Team, is delivering on a very predictable schedule. They are saying, we are going to use those vaccines, that is the Johnson & Johnson vaccines, in the hard-to-reach area. That way, we don't have to go there twice. Okay, you only go there once, and you vaccinate, and you leave. I mean, that is the power of predictability of access to vaccines. But if they don't know that when the vaccines will come, what type of vaccines, it's difficult to make such calculations. I just wanted to supplement that. But then the question from our journalists about the size of the lockdown. I mean, we cannot prescribe the size of a lockdown to a country. I think you have to do a couple of things. Implement your public health and social measures. So do testing, and then if you do look at that, you can have it can enable you to identify the hotspots, and that will become an alert. And then you can use that to say, okay, are you targeting a district or a commune or a whole region? And then based on the information that you gather from your routine testing, coupled with the public health and social measures there. So it's broad frameworks that we are providing that needs to be customized at country level and to make informed decisions that will guide the pandemic. But we cannot give you a blanket thing and say, okay, if you have 10 cases, you lock down the whole zone or you lock down the whole district.
All right, thank you. Let's move on now to a question that's coming from Pauline Kairu, and Pauline is working with the East African. I will combine her question with another question coming from Judith Akolo, who asks if the coronavirus has now mutated to being a more lethal virus. So the wording from Pauline is that she says a doctor here in Nairobi, specifically a consultant cardiologist at the Nairobi hospital, has released a statement saying that they have been seeing quite a few bad cases of COVID-19 in patients who are fully vaccinated with AstraZeneca vaccine. He said that the Delta variant represents the majority of these cases that the hospital is seeing. But yet, as people, we have persistently been told that being fully vaccinated with a double dose of AstraZeneca would protect us against severe disease. But it seems that is not holding out to be true, as said by the doctor. So the question is, what do you have to say about this new information? And should those that have already been vaccinated with AstraZeneca make an effort to get vaccinated with other vaccines, such as Moderna or Pfizer? And as I said, I'm also combining that with a question from Judith Akolo, who is asking if the virus has become more lethal.
So, Judith, let's start with the question of, has the virus become lethal? I said earlier, and I'm just repeating myself, that science learned so much about this virus in a very short time. But I'm also saying that we should be very careful and be humble enough to say that we are still learning about this virus, especially what we call the pathogenesis and the disease spectrum of this virus. And I think earlier on, in answering, I think that was Sophie's question, I said that we continue to learn more on how this virus is behaving. And for example, when we started this pandemic, we thought that young people were infected, but they would not fall sick. Now we know that they do. And we also knew that the rate of reproduction of the virus was like 2.0. We now know that with the Delta variant, it's about 8. So we continue to learn and new information every day. Now, with respect to whether the Delta variant is causing more disease, severe disease, and amongst people who are vaccinated, we have not yet seen comprehensive effectiveness studies. Okay, and effectiveness studies are studies that are conducted in the community as people get vaccinated. You follow them, and you can actually match the input and output, which means that you see what vaccine somebody has received, you follow them up, and then when they are sick, you track the severity of that. So the cases that the doctor, the good doctor in Kenya is reporting, I'll call them anecdotal cases there. And that you can't use those cases to inform science. You really need studies, progressive studies over time with a reasonable sample size to determine by vaccine category, whether it is AstraZeneca vaccines or the Pfizer vaccines or the Johnson & Johnson, and you need that follow-up period there in order to arrive at that. So we should be very careful that a doctor says that they saw a patient that had received X vaccine or this particular vaccine and was severely ill. I would not, that is not how science works.
All right, thank you very much. We are just about to run out of time, but let's take a live question that is coming from one of our regulars, and he is Paul Adepoju. Paul, please go ahead with your question.
Yes, thank you very much for this opportunity. So I have a question for Dr. John regarding the longer term approach towards tackling diseases in Africa, and which is contained in the One Health Initiative, especially considering diseases like Ebola and the Marburg virus disease are usually connected with animals. But we have human activities that continue to put some African regions at risk of these diseases. So what is being done to really accelerate the implementation of One Health approaches in African countries? Because I've read the report from African CDC on this. I would like to know whether there is an update on One Health initiative from the African CDC. Thank you very much.
No, thank you, Paul. I think you yourself have written extensively in a very high-end journals on some of these issues. So I think it is clear that what is happening with respect to emerging and re-emerging of infectious diseases in Africa and across the world is not anything that is surprising. I think there are at least 4 factors that are contributing to the emergence and re-emergence of diseases. One is the human population. We're growing very fast. I think the continent, when our continent, most countries in Africa achieved independence, I think we were around the late 1950s, early 1960s, we were less than 350 million people on the continent. And today we are 1.2 billion people. I give you an example. In DRC in 1976, the population was like 23 million people. And that is the period when Ebola was identified. And today, DRC is a country with about 100 million on the same mass surface area and trying to nourish 100 million people and the same amount of land. People have to now encroach and go into areas that they were not used to, going into what we call intruding into different ecosystems. And that is why if you look at the frequency of occurrence of Ebola in DRC, it has almost increased. I mean, it's almost like every year you have an Ebola outbreak in DRC, which previously it used to be like 10 years or 20 years before you see a reoccurrence of Ebola there. The second thing, as I said, is that people are encroaching into the territories that were not previously, human beings were not venturing into that, of course, for many reasons, looking for food, housing, agriculture, and all whatnot. Thirdly is movement of people. As many people are populating the world, we move very quickly. Just see how quickly it took for us from the virus that was recognized in December 2019 to spread across the world. Okay, very, very quickly. Within less than 1 year or even 6 months, the virus has spread across the entire world. I think those are some of the factors that there's not much you can do with that. But we can, as I've always said, you cannot prevent the emergence of diseases, but you can do something to blunt their spread. Okay, and that is where we should, as a continent, be in reinforcing our health systems in areas of workforce development, in areas of surveillance, in areas of laboratory testing. And that is the kind of partnerships that we have been working with Resolve to Save Lives before this pandemic. And I can make a case that in those countries that we had that kind of partnership, like DRC, Cameroon, I believe Nigeria, and other countries, they are using those systems to address the emergence of these diseases and tackling this pandemic in a very, very remarkable way. So I think, Paul, we have to all collectively argue and support governments and private sector to engage in strengthening our health systems so that we can use that to tackling and addressing the One Health issues. And that's also the reason why we have a meeting coming up in November, which will be devoted, a conference that will be devoted uniquely on One Health on the continent.
Thank you very much. It's time now for us to have our roundups. I'm just catching those key important points that our two panelists would like to leave with us from our briefing today. So let me give the first opportunity to Mrs. Amanda McClelland. Please just summarize your main headline points for us.
Thank you so much. I think the main headline is that we still have a long way to go, and vaccines are extremely important, but until we get there, public health and social measures remain an important tool, both at the individual and community level. And we hope that this framework, in collaboration with Africa CDC and WHO, helps provide a framework for countries to better use data to inform decision-making and communicate with their communities on how best to protect themselves and their neighbours.
All right, over to Dr. John.
No, thank you. I think my main message today is that we should, as a continent, agree that we need to sign a social contract that does two things. One is that as the vaccines come in, let's go to the vaccination centers and get vaccinated. The social contract says I have signed a contract with myself to get vaccinated. It will save my life and also save my loved ones. And then, of course, save my community. That is a unique contribution that we can all do in this. We don't need to be forced to get vaccinated. We just need to take on that. The second social contract is that know your COVID status. By knowing your COVID status, by opting to take a rapid antigen test, you can actually know that you are infected. In COVID infection is not a death sentence. You can actually extract yourself from the community, stay home, and after a week or so, you get you recover. If you are not sick, if you are sick, you'll be managed properly. But you actually cut the chain of transmission. Those are two areas of a social contract that Africa CDC is calling the continent to take on. We are in for a long haul. As I said earlier, the situation might get worse before it gets better because our vaccination rates are very, very low on the continent. We continue to learn more about these viruses. New variants are emerging, excuse me, and they are challenging our knowledge of how these vaccines work. So I think, but if we sign that social contract and we implement the public health and social measures together with the testing, together with rolling out vaccines, we stand a better chance of blunting the arrival of wave upon wave that is impacting our economies in a very dramatic way and impacting our lives in a very, very dramatic way. We should have to have a long-term view of managing COVID on the continent, not a very narrow perspective of we are responding to an outbreak. That acute phase is over. I think we really need to look at a comprehensive approach by signing a social contract.
Thank you. Thank you very much. Let me thank our two panelists that we had today. We were graced by the presence of Mrs. Amanda McClelland, and she is the Senior Vice President of Prevention of Epidemics at the organization Resolve to Save Lives. We were also joined by our usual host, Dr. John Kengasong, who is the Director of the Africa Centers for Disease Control and Prevention. And they gave us a lot of information on the importance of vaccination, but also very importantly, on the need to continue to observe those public health and social measures. We also heard about the lessons that we can learn from other African countries. And today, Dr. John was speaking about what Morocco is doing. So that brings our press briefing to an end. Let me thank you, colleagues from the media. Let me thank my colleagues from the African Union and from the Africa CDC who've made this broadcast possible. Let us meet again next week on Thursday at the same time. Bye-bye for now.
Bye-bye. Thank you, Amanda.